So we got involved and signed a partnership with the Indiana Hospital Association, the Indiana State Department of Health, to provide this opportunity via a SHIP grant. And what that is the Indiana Small Rural Hospital Improvement Grant program. And there are multiple different arms of this program, and we are the cohort that's using simulation to promote patient safety. And we are at the end of year one. Many of you have seen us before. We've actually come to your facilities and did simulations on topics that you're interested in. And that's what we would be doing this time if it were not for the pandemic. But we're flexible. So that is how we got here today. So what we're going to do is we're going to first take a pre-course test. And I will show you how to do that here in just a minute. And then we're going to have a few presentations. We have a couple presentations, and then actually 3 presentations, and then a couple of virtual simulations. And we'll watch those, and then we'll debrief. So whenever we are watching either the presentations or the simulations, I encourage you to either write down questions that you want to ask or put them in the chat box. And then we will discuss those after the presentation or simulation is over. And then after those presentations and simulations, there will be a post-course test and evaluation. Those tests, as everybody knows, just helps us show that the training that we're doing is effective. And then the evaluation is for our program to make sure that we are giving you what you want. That is especially important with these virtual simulations because it's a first for us. So we want to make sure that we're doing things the right way. So here is the pre-test. So what you're going to do is you can take your phone, the camera on your phone, if you have an iPhone, or if you have a QR reader on an Android, and scan over this QR code. If you are in a large conference room, it may be easier just to type in this website onto your phone. Okay, we're going to go ahead and get going here. Okay, so our faculty for this training, we have a couple great presenters. Jen Jager is a RN in the NICU currently. She has 25 years experience in NICU and PEDS, 20 years as a PALS instructor, 8 years as an NRP instructor, and she's been helping us in simulation for 5 years. She is going to be giving lectures on the pediatric shock and hypoperfusion, as well as respiratory emergencies. Thomas Miller is a registered respiratory therapist, and he is the assistant manager of respiratory therapy at Union Health, which includes Union Hospital, Terre Haute, and Clinton. And at Union Health, respiratory therapists place place PICs and insert IOs. So he's going to be doing a presentation on how to insert an IO. So without further ado, we're going to go ahead and turn it over to Jennifer's presentation on pediatric shock and hypoperfusion. So you guys are going to have to bear with me today. I am unexpectedly working from home, which means one computer screen, and I'm not used to that. So I'm going to be going back and forth here, pulling up all of our videos. So give me just a second and I will start Jen's presentation.
Hi, I'm Jennifer Jager. I am a PALS instructor from the RIC Simulation Center in Terre Haute, and I'm going to talk to you about care of pediatric shock and hypoperfusion. There's my contact information if you have any questions. Shock is a critical condition that results from inadequate tissue delivery of oxygen and nutrients to meet the tissue's metabolic demands. That is your basic definition. It can come from inadequate blood volume or oxygen carrying capacity, inappropriate distribution of blood volume and flow, impaired cardiac contractility, or obstructed blood flow. And we're going to break that down into more simple terms. The child having fever, infection, injury, respiratory distress, and pain all make the shock worse. That's because it's causing increased demand for oxygen and nutrients on the tissue. The goal for treating shock is to improve oxygen delivery. That's basically what your goal is. So it's characterized by an effect on the systolic pressure. Compensated shock has a systolic blood pressure within normal range. So when you're calculating systolic blood pressure for children, it's 70 plus 2 times their age in years for children aged 1 to 10. For over 10, you go with adult parameters. For less than 1, your goal is for the blood pressure to be greater, the systolic blood pressure to be greater than 70. So compensated shock means your blood pressure is in normal range, but there are signs of inadequate tissue perfusion. So these are the signs you're going to be looking for in assessment when you're assessing your pediatric patient that comes in. Tachycardia, cold, pale, mottled, or diaphoretic skin, delayed capillary refill, so it's going to be greater than 2 to 3 seconds. Weak peripheral pulses, so you're going to compare your central pulses to your peripheral pulses. And narrow pulse pressure on your blood pressure. There's not much difference between your systolic and diastolic. They're not peeing much. Mom reports she hasn't had many wet diapers, or vomiting. So those are all the signs that will tell you the patient's in shock, but still compensated. So hypotensive shock is when the body's physiological attempts to maintain the blood pressure and perfusion are no longer working. The body's done what it can, so your blood pressure is starting to change. And one of the key clinical signs is the changes in level of consciousness. They just aren't acting as they should. You should expect a toddler to be scared of you, and they're not acting afraid when you come in the room. Early recognition and rapid intervention are critical to stopping that progression from compensated shock to hypotensive shock, because that's quickly going to lead into cardiac arrest. Some warning signs that the progression is happening from compensated to hypotensive. Your tachycardia is getting worse. Your heart rate was in the 160s and now you're in the 190s. Diminishing or absent peripheral pulses. You're having a harder and harder time finding those radial pulses. Weakening central pulses. You're having a harder time finding your femorals or your brachial pulses. A narrowing pulse pressure. When you take a blood pressure, those numbers are getting closer and closer together. Cold distal extremities with prolonged capillary refill. Decreasing level of consciousness, they're getting less and less interactive. And then the blood pressure dropping is going to be a late finding. So your goals for managing shock, and this is all types of shock, improve oxygen delivery. So per PALS guidelines, 100% non-rebreather on everyone is going to improve oxygen delivery. We want to balance tissue perfusion and metabolic demand. You want to reverse any perfusion abnormalities. You want to restore organ function, and you want to prevent that progression to cardiac arrest. So we're going to talk about the fundamentals of shock. You're optimizing the oxygen content of the blood. You're improving volume of the blood and distribution of cardiac output, reduce oxygen demands, and correct metabolic derangements. High concentration oxygen, non-rebreather to deliver 100% O2. You can do invasive or non-invasive mechanical ventilation as appropriate. And then if their hemoglobin's low, because that's what's carrying your oxygen, you want to consider a packed red blood cell transfusion. To improve the volume and the distribution of your cardiac output, if you're dealing with hypovolemic shock, rapid administration of isotonic crystalloids. So that is your infusion of normal saline or lactated ringers. Distributive shock or septic shock, also rapid administration of isotonic crystalloids, but also you're probably going to need to add some vasopressors. Cardiogenic shock, it's pretty rare in children, but you might see a child that's been in SVT for some hours. Slow infusion of fluids, inotropic and vasodilator therapy, and you want to consult experts early, so you're going to be calling for transport very quickly on that one. Obstructive shock, probably the most common in kids on that one's going to be a tension pneumothorax, maybe from a trauma. You want to support cardiovascular function. You want to identify what the problem is and treat the cause. So ways to reduce oxygen demand on the body. You want to address the common causes of increased oxygen demand. So increased work of breathing, pain and anxiety, and fever. So support breathing as they're comfortable. Some kids are more comfortable with a nasal cannula. They don't like the feel of a mask all the way around their face. Some kids will let their mom hold the mask up to their face, but they don't want that band around their head. So whatever's comfortable for them. Consider sedatives or analgesics, but be careful that you don't knock out any respiratory drive. Controlling the fever with Tylenol or other cooling measures. Maybe ask mom to take the fleece blanket off. You don't want them to shiver, but they shouldn't have too many layers on. And use parents. You know, if you need to put a Band-Aid on something, ask the mom to do it. Generally, kids don't want a stranger near them, so anytime that you can avoid being in their personal space, you're going to decrease their anxiety and fear. Correcting metabolic derangements, hypoglycemia, this is a big one. Kids use a lot of sugar, so if their glucose is low, you can easily correct that. And if it's extremely low, it can lead to seizures and brain injury. Hypocalcemia, it's essential for cardiac function, so that may be something you want to check, look into. Obviously, you're going to do a series of electrolytes. Hyperkalemia, that's going to result from renal dysfunction. Acidosis, you're going to have that. And then metabolic acidosis on your blood gas. It's going to develop when you have a production of acids from the tissue perfusion being inadequate. It can be caused by renal or GI dysfunction. So you want to just keep the history in your head, things that mom have told you that may give you clues as to what's going on. So how do you know that you've treated the shock? You have a normal heart rate and blood pressure for age. You have normal pulses. So your peripheral pulses and your peripheral pulses are equal. Your capillary refill time is less than 2 seconds. Their extremities are warm. They're behaving appropriate for their age. The urine output is adequate. The lactate has normalized and the base deficit is reduced. So now we're going to talk about the management of shock. We're going to position them appropriately, airway and breathing, vascular access, fluid resuscitation, of course, monitoring and frequent reassessment, any labs that you might do, medication therapy, and then consultation. The most common shock in children is hypovolemic shock. There's many reasons that they may be low on fluids. Diarrhea and vomiting are very common. Hemorrhage from trauma, and that could be internal bleeding or external bleeding. Inadequate fluid intake, frequently you see that. We see that frequently here in children that have had a tonsillectomy. They start refusing to drink, and then the longer they go without drinking, the more it hurts to drink. So you kind of have a vicious cycle. DKA, maybe kids have been undiagnosed with type 1 diabetes. Third space fluid loss, and large burns. So any of those scenarios, you're going to have low blood circulating in the vessels. Signs of hypovolemic shock, they do have a patent airway. They may be breathing fast, but you don't see any signs of respiratory distress. The lung sounds are clear. There's no mucus drainage. Chest x-ray looks normal. They don't have a history of asthma, but they're breathing fast. Tachycardia, and that heart's pounding away. That pump's trying to pump faster to get more blood through when they just don't have enough volume. Initially, you're going to have an adequate systolic blood pressure, or you might have some systolic hypotension, and the pulse pressure is going to be narrow. Weak or absent peripheral pulses, so you want to check those. Normal or weak central pulses, delayed capillary refill, so you're looking for a cap refill time of 2 to 3 seconds. Cool, pale, mottled skin, and also diaphoresis, that's pretty common. Dusky, pale extremities, changes in level of consciousness, and again, not enough urine output. Mom reports there hasn't been a wet diaper today, things like that. And again, changes in level of consciousness when you have a toddler that should be scared of you and totally doesn't care what's happening or not fighting you on getting a blood pressure, things like that wouldn't be normal. More specific symptoms for hypovolemic shock. Their eyes appear sunken. They have dark circles under their eyes. Their lips are bright red. Their mucous membranes are maybe completely dry. Their mouth is sticky. You can check their skin elasticity. And with children less than 15, 18 months old, you can check their fontanelle. To appropriately assess the fontanelle, the baby should be at a 45-degree angle, and you assess whether it's flat, level with the plates of the skull, or if it's sunken in, that would be a sign of hypovolemia. So treatment of non-hemorrhagic hypovolemic shock. They've have a history of vomiting and diarrhea. They have an explanation for why there would be dehydration with no signs of blood loss. So your treatment would be normal saline or lactated ringers, 20 cc's per kilo over 10 to 20 minutes. When that infusion's done, you want to reassess your pulses, you want to reassess your capillary refill, you want to reassess the level of consciousness. If those things are not improved, you're going to repeat that bolus again. And again, reassess is key. And you can repeat that bolus a third time. Kids generally improve very quickly. If you get their fluid levels normal, they feel good in no time. If there's not failure to improve after 3 boluses, the fluid loss is underestimated. You need to reassess what type of fluid replacement you need to do. Your assumptions about the cause of their shock may need to be reassessed. You may need to seek specialty consultation. So hemorrhagic hypovolemic shock. There was a trauma, there has been bleeding, you know that they've lost blood. So based on that, knowing that a child's estimated blood volume is about 75 cc's per kilo, and that's how much fluid they have, maybe there can be some estimation of how much they've lost. You want to give, if you're using, fluid replacement, you want to give about 3 milliliters of the crystalloid, the normal saline or LR, for every 1 milliliter of blood loss. So 3 boluses may be what's necessary to replace 25% blood loss. However, if you have packed red blood cells available, that would be more appropriate, more ideal, and that bolus is 10 milliliters per kilo. Distributive shock, moving on, that's your septic shock. It's characterized by an inappropriate distribution of blood volume with inadequate organ and tissue perfusion. So the common forms are, like I said, what you're going to see is septic shock, possibly anaphylactic shock, or maybe rarely neurogenic shock. In septic, you're going to have vasodilation and venodilation in the venous system with increased capillary permeability. So the blood vessels have lost their tone and they're leaky. So your blood isn't staying really where you want it to. In anaphylactic shock, there's venodilation, arterial vasodilation, and increased capillary permeability, along with pulmonary vasoconstriction that reduces cardiac output. So that kid has a lot of things going on to correct. In neurogenic shock, they just have a generalized loss of vascular tone that's usually following cervical spine injury. The cause may not allow, the injury may not allow the heart rate to increase to help compensate for that hypotension. So that's especially dangerous and thankfully the least frequently seen. For distributive shock, you want to make sure the patient has a patent airway. Know that they're going to have tachypnea, and again, usually without increased work of breathing, unless they have a pneumonia that's caused this, so know that that's a possibility. They're going to have tachycardia. With distributive shock, you're going to have bounding pulses, so kind of opposite of the other type. They may have brisk capillary refill if they're in warm shock, or they have delayed capillary refill of cold shock. So warm shock's going to be the warm flush skin because the blood vessels are all dilated, or pale mottled skin and delayed capillary refill if there's not much circulation to the skin. You're going to have hypotension with a wide pulse pressure in warm shock, and again, a narrow pulse pressure in cold shock. You could even have a normal blood pressure. They are going to have a change in level of consciousness, like we've talked about, not enough urine output. Kids sometimes have a fever when they're sick, or their temperature goes low when they're very sick. And then also you want to watch for the purpuric rash. So your goals of treatment for septic shock, distributive shock, is restore hemodynamic stability, and you want to identify and control the infection. So initial treatment, the 100% O2 non-rebreather, if possible, support ventilation as necessary, monitor their respiratory status, monitor all their vital signs. Very, very important in treatment of shock is establish vascular access. The general rule of thumb in a kid who has hypotensive shock that you need quick access is allow 2 to 3 minutes to access a site peripherally, and if those are unsuccessful, go directly to an IO. Know that in distributive or septic shock, 3 or 4 boluses in the first hour wouldn't be uncommon. So you would give a bolus, reassess, give a bolus, reassess, and it wouldn't be uncommon to give 4 in that first hour. Continued treatment would be monitor your electrolytes and correct those as necessary. Get cultures and then give antibiotics early. Consider a vasopressor drip, possibly hydrocortisone. Likely you're going to get consult expert advice on that. A second vascular access site would be a good idea. Identify and correct any metabolic derangements, and then more diagnostic tests to make sure we're treating the right thing and normalizing everything. The treatment of anaphylactic shock is IM epi. A second dose or an epi infusion may be needed in severe cases. You can give a normal saline bolus. You can use albuterol as needed for any bronchospasms. Antihistamines, an H1 blocker in addition to an H2 blocker, and corticosteroids. Treatment of neurogenic shock, allow the child a position of comfort if they're stable. If not, place in Trendelenburg if it doesn't compromise breathing. High concentration oxygen, non-rebreather, again, that 100% O2 is never a bad idea in a PAL situation. Consider CPAP, non-invasive PPV, or mechanical ventilation. You could administer a trial of a bolus and reassess and assess response. Use vasopressors as indicated, and then provide supplementary warming or cooling as needed to normalize the temperature. We're going to talk about cardiogenic shock, and again, this one isn't seen very frequently. Probably the most common thing would be SVT or a child who has a history of congenital heart disease, and in that case, frequently the parents are going to know more than you do, more than any of us do. Signs are going to be tachypnea and increased respiratory effort with this one. They're going to have retractions, flaring, grunting, and that's going to be from the pulmonary edema, so you're going to be ruling out several things. They're going to have tachycardia. a normal or low blood pressure with a narrow pulse pressure. Weak or absent peripheral pulses, again, the signs of shock, delayed capillary refill, cold extremities, signs of congestive heart failure. Possibly, depending on their age, you could see jugular vein distension, but of course toddlers have a short, fat neck. It's kind of hard to see. Hepatomegaly, you should not be able to feel the liver in children, so if you can feel their liver, that's going to be a positive sign. Pulmonary edema, maybe you can see on chest x-ray, hear crackles. Cyanosis, again, the cold, pale, mottled skin, an inappropriate level of consciousness, and not enough urine output. So critical concept in cardiogenic shock. The increased respiratory effort often distinguishes cardiogenic from hypovolemic, but then also you have to discern it from respiratory emergencies. Hypovolemic shock is characterized by tachypnea without increased work or breathing, but cardiogenic shock's going to have, that child's going to have retractions, grunting, and using their accessory muscles. And also in cardiogenic shock, there's going to be a decreased arterial O2 sat because of that pulmonary edema. So specific treatments improve the effectiveness of the cardiac function and minimize metabolic demand. So again, we're keeping them calm, we're keeping any pain under control, we're keeping their temperature normalized. Gradual fluid resuscitation, so this bolus is going to be lower and slower, so 5 to 10 milliliters per kilo over 10 to 20 minutes. You're going to give oxygen, you're going to assess for the pulmonary edema, you're going to call for expert consultation early. There are meds to improve myocardial dysfunction. Maybe they need a dose of Lasix, maybe they need milrinone, diagnostic studies, an echo, chest x-ray, those kinds of things, an ABG, and mechanical circulatory support, which is going to happen at a more specialized children's hospital. Obstructive shock is our next topic. The cardiac output is impaired by physical obstruction of blood flow. So something's causing the heart to be squeezed so that it's not able to pump. Examples would include a cardiac tamponade, a tension pneumothorax, or a ductal-dependent congenital heart defect. The main objectives in your management is to correct the cause of your obstruction of cardiac output, obviously, and then you're going to restore tissue perfusion. Specifically, a cardiac tamponade, if you're going to have a good outcome, that requires rapid ID and immediate treatment. Giving the fluid administration, the fluid bolus, it's going to give you a temporary improvement, and then things are going to go back to where they were. Your reassessment is very important. Consult a specialist early, get them on the phone. Pericardial drainage guided by ultrasound or fluoroscopy is the treatment, and an emergency periocardiocentesis can be performed in the event of impending or actual pulseless arrest. So recognize early, get a transport team, specialty team on the way. Tension pneumothorax, I would think this would be the most common that you would see. Treatment would be an immediate needle decompression and then followed by chest tube placement. So this is more specifically covered in PALS in detail, but an 18 to 20 gauge angiocath over the top of the child's third rib, second intercostal space on the midclavicular line of the affected side. Congenital heart defects, and specifically a ductal-dependent lesion. If you have a newborn who's brought into your facility and you are seeing signs of this cardiogenic shock, you're seeing the pulmonary edema, maybe you're seeing a hepatomegaly, and this is a newborn, what may be happening is they have a ductal-dependent lesion and that ductus is closing. In fetal circulation, as you see on the left, the ductus arteriosus is an opening that, as a fetus, is normal to be open between the aorta and the pulmonary arteries. And as the baby, once the cord is clamped, pressures change, and over the next hours to few days, that opening gradually closes. When that closes, the baby no longer has any mixing of blood, and they're going to have a cyanotic episode, and the heart's going to have a lot of problems delivering oxygenated blood to the baby's body. So once this is recognized, it's important to give a medication called prostaglandins quickly. It's a hormone that allows that ductus to stay open until the child can have surgery to repair this. So again, early recognition is important. Your key age in this is going to be days old, and you need to consult a transport team to come pick up this patient early. Thank you.
Okay, does anyone have any questions for Jen?
Hi, I'm Jennifer Jager. I am a PALS instructor from...
Sorry about that. It's okay, we're used to the silence when it comes to question time. If no one has any questions, we will go ahead and move on to our presentation on intraosseous needle insertion by Thomas Miller. So I'm going to go ahead and get that started. And once again, if you have any questions that you think of during the presentation, you can put them in the chat, and we will answer them after the presentation is finished, or you can ask them whenever we're finished here.
Hello, my name is Thomas Miller, and I'm with the Rick Center here today. We're going to talk about IOs and the insertion on pediatric patients. We're going to be utilizing our pediatric HAL here, our simulator friend, and we're going to demonstrate how that's done. Remember that with IOs, anywhere you read essentially in American Heart Association or the AHA regarding NRP and specifically relating to PALS, anytime that they talk about IV, it's always IV or IO, and they are very interchangeable. The IO is grossly underutilized for a number of reasons, but as healthcare providers, to be honest with you, we've got to get past that sense that we have internally that it's a kind of a barbaric thing to drill into someone's bone. It's a very, very easily accessible and rapidly accessible route to instill fluids as well as medications. So just remember that any drug or fluid that can be given IV can also be given IO. And the IO is usually very quick to assess, unlike at times, especially when we talk about a pediatric patient being hemodynamically compromised in shock, that their venous access is extremely difficult. So in those situations, think IO first, and that's okay to do. So we're going to demonstrate the IO here. We utilize here the Easy IO drill, which makes it extremely quick and easy to get the needle into the bone. And then we're going to use, with pediatric HAL here, we're going to use the Easy IO 25 millimeter needle. And so it comes in a kit. We're going to just quickly look at that kit here. I hope this is what your institution utilizes as well, because everything is self-contained. So of course the needle itself, there are three main needles. The blue that you see here is the 25 millimeter. The pink ones or the red ones are the short ones. They're 15 millimeter, really reserved for babies. And then we have the yellow one, which is the longer one. It's a 45 millimeter needle, and we usually access adults' proximal humerus sites with those. So, for peds patients, the blue one is the one to go to. Also contained in here is what they call the Easy IO catheter. In this little pig tubing here is what we're going to flush with saline and attach it to our needle after we insert it into the bone. Our safety device for our IO needle after we do the insertion so we don't harm ourselves or other healthcare providers at the bedside. And then every kit also comes with an armband, and it's important, as the information designates here, where you put the insertion site, your name, and the date. So these, and time, these IOs are good for 24 hours. We should remove them within 24 hours, and it really gets us past that emergency time where we need access quickly, and we can look then at other access points after we have the patient stabilized. So 24 hours is the cutoff for IOs. So the site that we're going to use on pediatric, on our patients here, is we want to use the proximal tibial site. You want to locate their medial tuberosity. It's that little bone just inferior to the patella, okay? You put a finger there, and you want to go about 2 to 3 centimeters inferior to that. So our insertion site will be here. And if you can feel like your own tibia or a patient's tibia, what you want to do is you want to feel that flat part of this tibial bone that's going down here. You want to just drill in the middle of that flat access point of the tibial bone there. So I'm going to wipe it off with some alcohol here. Right here. This is how the needle attaches to the drill. It has a little magnet that holds it on there. It's not super strong, but it's strong enough to hold it on. When you remove the cap from the needle, just hold the needle in place and remove it like so we don't pull the needle back off the drill. We're going to locate our landmark. Remember, it's about 2 to 3 centimeters below the medial tuberosity on the tibia. So we're going to go right below where my finger's at. You want to find that flat part of the bone, 90-degree angle. You go into the skin till you hit the bone, and then you apply pressure to the drill with a moderate amount of pressure pushing down. Remove the drill from the needle. The most common question we get is, how do we know that the IO needle is in the proper place? And the first thing that you'll observe when you remove that drill is that your needle's setting taut into that bone. It's not floppy, it doesn't move around. So long as it's stable and sturdy, that's your first sign that you're in the right position. So next, you want to hold the bottom portion of the IO needle down here with one hand, and the top portion is going to unscrew off. And that's the trocar part. That's the part that actually drills into the bone, leaving the needle that we're going to instill fluids and drugs through. So we're going to set this over to the side. Next, we want to attach a dry syringe to the needle itself and aspirate out. What we're looking for when we do that is a little bit of bone marrow, which is the second way we confirm proper placement. That bone marrow, if it comes up, is going to be a bubbly substance. It's not blood, so it's not free-flowing. And you won't always get it, which is not telling you that you're not in the proper location. You'll get it most of the times, but not every time. So after we remove this, we need to put on what's called the Easy IO stabilizer, and this is going to attach just like so. It goes down over the needle. We remove the sticky portion of it, and then it sets in place, holding the needle in good position so it doesn't get dislodged. What we worry about with IOs and how IOs get dislodged and knocked out is if something hits them from the side. And so this Easy IO stabilizer protects that needle, and it gives you a good access then. Next, we attach the Easy IO catheter, which has been flushed with saline. We put it into position, screws onto the hub here, and then we flush it. And it should flush easy. As we flush it, and as we instill fluids too, we always want to check the posterior side of their leg to make sure it's not getting hard or cold, or obviously increasing in size from swelling. And that flush should just flush easy. Once we get that into position, your flush syringe comes off, and here's your Easy IO catheter attached. And then it's ready to receive any fluids or any drugs that you may want to give via IO access. Keep in mind that these Easy IOs are only good for 24 hours. They're a quick access. They're a great access to give any fluid or any drug that you need to. And again, please consider an IO initially over an IV in patients who are hemodynamically compromised. Thank you.
Any questions for Thomas on IO?
Hi, this is Almiri Oosthuizen with Cape Town Emergency Medicine, here today to talk about insertion of intraosseous access in a child. Intraosseous access is an emergency procedure to establish vascular access where conventional techniques have failed.
One moment, please.
Before
It's like I'm playing somebody else's video here. Okay, sorry about that. Told you I might have problems with only one computer screen. Okay, looks like we got a question here. If IO is done in the field, do they recommend antibiotics?
Hey, great question. Can you hear me okay?
Yes.
Awesome. Great question. No, actually, it's just like an IV. You just clean the site with alcohol in the field. And studies have shown, numerous studies have shown that there's no increase of infection with an IO versus an IV. Again, just remember an IO is only good for 24 hours and then it needs to be pulled. That's a great question.
Okay, so just to reiterate, if an IO is done in the field, you do not need to give antibiotics. And the question was saying that they used to have to give antibiotics, but it is just like an IV. They do not need to have antibiotics just because an IO was started in the field. Okay, any other questions regarding IO? Anybody? Okay, we're going to move on and we are going to do our first simulation. So I'm going to start the simulation and be watching in the chat. If you have any questions or thoughts during the sim, go ahead and put them in the chat, but then as well, I may be asking you some questions during the simulation. So be watching the chat as well as the sim.
Hi, my name's Jennifer. I'll be your nurse today. What's going on?
He just started throwing up blood at home.
Why has he had surgery? Ooh, he smells.
He had his tonsils out about a week ago.
Okay, okay. What physician did that procedure?
Dr. Jones.
Has he been drinking like he's supposed to?
Not really. I mean, he'll take a sip here and there, but he says it hurts and he doesn't really want to.
Okay. Has he had any the Tylenol with codeine or
Josh,
any
can you open
Tylenol
your
today?
eyes? Hey, bud. I'm sorry, what'd you say?
Has he had any Tylenol with codeine or any pain medicine today?
No, he won't even take that pain medicine. He won't swallow it. Josh, bud, come on. Come on, bud. Open your eyes.
Carrie, could you get Dr. Thomas and come help me in here? He had a tonsillectomy a week ago. He's not been drinking much. Has he been peeing normally?
I wouldn't say so. I mean, he's not been drinking.
Okay. His heart rate's in the 150s and he's not really responding to us much.
Okay.
You open your eyes, bud?
Better get an IV started.
How long ago did this start?
He just set up. He was taking a nap on the couch and he just set up and he just puked blood everywhere.
Just one time?
Yeah.
And he's been like this?
Yeah, I just can't get him to really open up his eyes and talk to me.
Okay.
I mean, he's been real tired. He's been taking a lot of naps.
There we go.
I just thought it's because of the surgery.
Yeah.
Okay. I'm just gonna look in his mouth here. Okay. And since the surgery, he hasn't really had a lot of bleeding. The surgery went fine.
Yeah, it went fine. He just says it hurts.
Okay.
But he won't take his pain medicine. He won't swallow it.
Okay.
Peripheral pulses are pretty weak and thready.
Weak and thready?
Yeah.
You're gonna start a line?
I think I'll try.
Okay. I'm gonna have them contact Dr. McCanna, the ear, nose, throat surgeon, and then, can we get him on some oxygen as well?
Oh, yeah.
Yeah? Be okay? And I'll be right back. Get that line going.
Okay.
Alright, buddy, I'm gonna put some oxygen on you. Get this mask right over your face.
Can you open your eyes, bud? Come on, look at me.
Did he stay overnight the night of surgery?
No, we got to come home.
Good deal. So no problems the day of surgery, no bleeding that day? Did he start out drinking well for you and quit, or?
He liked popsicles, but then he started saying it hurt too bad. And then he just got real sleepy. He just wanted to watch TV and take naps.
Okay. I'm doing in case he
Yep, absolutely. Alright, buddy, I'm just gonna hang on to your arm for a second.
might be a little burn. You can yell and scream, but hold still.
Big poke.
Oh, and blue. Okay. Alright, kiddo.
Didn't flinch.
Good.
How are we doing?
I tried once and didn't get it. I'll try one more time.
Okay,
He
super.
doesn't have much.
I called Dr. McCanna, he's gonna come in, but
Do
it's
you
gonna
wanna
be a
come over
little
on
bit.
this side, and I'll just, are you good holding?
Big sides.
Whatever you want to do.
Can borrow your stethoscope?
Mm-hmm.
Thank you. I'm just gonna listen to it as long as you're real quick.
For a stick and make him cry.
As long as they're good and clear.
Okay, buddy. Another big stitch. Try to hold still. Yeah, I don't think this is gonna work.
No? All right, let's put in an IO
Okay.
and let me grab the kit here real quick.
We're having a hard time getting IV access, and what he needs is fluids. He's probably lost a lot of fluid because he wasn't drinking. And then a lot of times what happens with tonsillectomies is if there's some bleeding from the patches back there, the blood drains into the stomach, it's hard on the stomach, and it makes him vomit. So he's probably dehydrated from not drinking enough, and he's also lost some blood. So we need to give him some fluids quickly, and we'll kind of go from there. He'll perk up when we get some fluids back in him, but we want to do that urgently. His veins just aren't cooperating. He's so dehydrated we can't get an IV in. So Dr. Thomas is going to put He's going to put some IV access directly into his leg bone. So I don't think he's going to care, but it'll be a way that we can get fluid in fast and get him feeling better lots faster.
What's his name? His first name?
In his bone?
You can, yes. Blood's made in the bone marrow, so it's a direct access.
Does that hurt?
Bring your fluids.
It would, but I think he's feeling so bad it's the least of his worries. Yeah, are you going to do a 20 cc per kilo?
20 cc.
And how much does he weigh, Mom?
Saline.
About 50
Okay.
pounds.
So roughly.
All right, buddy, you're gonna feel a little needle prick here.
500 cc's normal saline.
Excellent. Good job, buddy. Good job.
Is it over?
Yep, it's in. It's done.
Let me borrow this real quick. Good placement. Looks great. Let me put this on here real quick. You don't have nerves in your bone, so you really don't feel that any more than an IV, okay? This will get us good access really quick.
How long does that have to stay there?
Oh, we'll leave it in for about a day, and then we can put a regular IV in him. But this is a great way to get him some fluids, and he needs some fluids right now, okay?
This is working nicely.
Awesome.
Very
Excellent.
good.
Excellent.
So Carrie's getting him some fluids ready. Already,
That's gonna make them all better.
It's going to help a lot. The ENT will probably come in and talk to you to see if he maybe needs to go to surgery to cauterize any blood vessels that might be leaking in his throat.
Why does that happen?
Tonsils have a high risk of bleeding about 7 days post-op is the highest point, and then if the kids aren't drinking a lot, it just kind of makes all the problems worse. So he'll probably have a good stern talk with their son about drinking better this time.
Okay. Josh, can you open your eyes?
He's looking a little pinker with the oxygen already.
How fast you want this running?
You can run over 30 minutes. If it'll go at 250 an hour. Or faster, faster not.
Can I get a clean washcloth to clean him up?
Absolutely.
Still thready and weak.
Use a clean wash right here. So on the phone to Dr. McKenna, talk
Yeah.
like we'd keep him here for fluids and he'll.
I think he's gonna evaluate him, see if he needs to go back to surgery, and
Okay.
probably we'll keep him here, yes.
Okay. So you'll be able to stay with him through all that, Mom.
Yes.
I got your fluids started.
Excellent. So when this bolus is done, we'll reassess his tachycardia and his perfusion and see if we need to give another bolus.
Yes.
Kind of go from there. Does that sound like a plan?
Fluids right now, okay?
This is working nicely.
Awesome.
Very good.
Excellent. Excellent.
So Carrie's getting him some fluids ready. Already,
You think that's gonna make them all better?
It's going to help a lot. The ENT will probably come in and talk to you to see if he maybe needs to go to surgery to cauterize any blood vessels that might be leaking in his throat.
Why does that happen?
Tonsils have a high risk of bleeding about 7 days post-op is the highest point, and then if the kids aren't drinking a lot, it just kind of makes all the problems worse. So he'll probably have a good stern talk with their son about drinking better this time.
Okay. Josh, can you open your eyes?
He's looking a little pinker with the oxygen already. if it'll go at 250 an hour. Or faster, faster than that. Did I get a clean washcloth to clean him up? Absolutely. When this bolus is done, we'll reassess his tachycardia and his perfusion and see if we need to give another bolus.
Yes.
Kind of go from there. Does that sound like a plan?
Okay. So other than the little video hiccup there, is there anything that we could have done better in the situation? Anybody care to share? What would you have done differently in your facilities? So I have someone saying that maybe we could have started the oxygen a little bit sooner. Anybody have any thoughts on that? It definitely wouldn't have hurt the situation to start oxygen a little sooner. In your facilities, is there anything that would have caused you any difficulties? All right. What went well in the simulation? Oh, I have someone say that they don't have an ENT in-house. So if you have someone coming in that had recently had surgery, that's somebody that you may have to go ahead and ship. Sarah, is that what you're saying? That person would have had to have been shipped out for surgery? Same thing. Several people are saying that there's no ENT. So what went well? Sarah's saying there was good communication and good job explaining to mom what was going on. How about from our subject matter experts? Do you guys have an opinion? Is there anything that you would have liked to have done better?
Rewatching the video, we forgot to do order a CBC, maybe a type and cross, and electrolytes. We should have done that early in the simulation.
Gotcha.
Even without an ENT in the house, you still can call whoever, whether the surgeon who did the surgery is on call or whoever's on call for them, to get advice. They still can be a consult even if they aren't in your facility or related to your facility.
So do we have preset orders for these typical situations? How about everybody that's watching? Do you have preset orders? I know I was just thinking in the ER, it's so common that when a patient comes in, you go ahead and draw labs, that it's easy to skip over that part when you're doing a simulation because it's just one of those things that's normal. It becomes something you kind of forget about. Brad, are you saying specifically for a pediatric shock patient?
Yeah, I
Or-
was wondering that same thing. If you have someone who you believe is in hypovolemic shock or cardiogenic shock, do you already have a preset algorithm of orders that's put into play at the beginning that you alter as needed?
From our experts, do you guys know if our ER has anything?
I don't believe that there's, I don't think we have a preset order for that, other than we would strictly follow PALS. The physicians, of course, are at the bedside. The ER physicians would be at the bedside. If we're on the PEDS unit, more than likely here in our facility, we would have a resident at hand and probably get a pediatrician on the phone. But we would follow PALS almost to a T. Would you agree?
Agreed.
Yeah.
And I know I can speak to the pediatric unit that there are no preset orders. But again, the PALS guidelines are going to direct you in the same direction to follow that path of needing to know blood counts and electrolytes for sure on that kind of a patient.
Okay, thank you.
So going off of that, everyone pretty much is going to be able to follow the PALS guidelines. I'm assuming that everyone working in the ERs are PALS certified. At
What
least,
makes PALS so tough is we just use it so rarely.
yeah.
And so when you don't practice something routinely, it's tough to recall it. It's tough to, at the tip of your fingers, kind of, remember all the numbers and the guidelines. And so that's why it's important to just simply review. And we love drills. We love simulations and we love drills. And that's why we fully admire you all for taking the time to do this training, because that's what you're doing is training, and training is so important.
Good point, Thomas. Does anybody have anything else they'd like to mention regarding the simulation?
I think I just want to say too that it's important to remember it's always a high stress, high anxiety situation when a child's involved. And it's important to not be afraid to speak up, not be afraid to question other members of the team if you're not sure. Everybody's stressed, and our memories, our calculations sometimes fail us. So if you're not sure, and maybe you're not right, but maybe it will trigger the physician to remember something that they should be doing, or don't be afraid to say in a respectful way, shouldn't we do a CBC? Shouldn't I draw that while I'm starting the IV? Those kind of questions.
Good point. Okay, I'm going to go ahead and move on to the pediatric respiratory emergency presentation. Give me just a minute and I will get that pulled up.
Hi, I'm Jennifer Jager. I'm a PALS instructor from the Rick Simulation Center in Terre Haute, and I'm going to be talking to you about care of pediatric respiratory emergencies. Priorities in managing the seriously ill or injured child is evaluation of their airway and breathing. You want to be alert for signs of respiratory distress and
Give me just 1 minute. Let me fix that for you.
I said, Laura, I was just going to say refreshing it's probably the way to go there.
Hi, I'm Jennifer Jager. I'm a PALS instructor from the Rick Simulation Center in Terre Haute, and I'm going to be talking to you about care of pediatric respiratory emergencies. Priorities in managing the seriously ill or injured child is evaluation of their airway and breathing. You want to be alert for signs of respiratory distress and or respiratory failure. Respiratory conditions are the main cause of cardiac arrest in infants and children, and intervening quickly restores respiratory function. Clinical signs that you're going to want to assess for is increased respiratory effort. In children, you're going to look at nasal flaring. You're going to look for intercostal, subcostal, suprasternal retractions. You want to look for inadequate respiratory effort, hypoventilation, or breathing that's not fast enough to maintain their oxygenation. You want to listen for abnormal airway sounds, for example, stridor, wheezing, or grunting. You want to observe for tachypnea. You want to assess the heart rate. You want to assess for pale, cool skin or any changes in level of consciousness. Respiratory failure. These are some of the signs. Marked tachypnea. They're breathing quite rapidly, but eventually that's going to slow down to become bradypnea or apnea when they wear out. Increase respiratory effort, then it'll become decreased, and then you'll have no respiratory effort. Poor to absent distal air movement, so when you listen to the lungs, you won't hear as much movement of air all the way to the bases. At first, the heart rate's going to be fast to compensate, but then as the child's body wears down, you're going to have bradycardia. You're going to observe for cyanosis, and then a late sign would be a stupor or coma where the brain's not getting enough oxygen. Some initial interventions for all respiratory problems would be support and open airway. You want to allow the child to assume a position of comfort. That may be sitting upright on the cart. That may be laying over mom's shoulder. Whatever way they're comfortable, try to allow them to maintain that position. Clear the airway. This is important in pediatrics. The younger the child, the more they rely on breathing through their nose. So you want to make sure you suction their nose if there is a lot of mucus and occlusion. Dried secretions can completely occlude their nasal passages, so you want to clean that out. Maybe in small infants, they have mucus in their mouth that they can't clear, so you'd want to suck that out. You want to consider an artificial airway to improve any airway patency. Some initial interventions for all respiratory problems would be monitor their breathing. So you want to monitor their O2 sat by pulse oximetry. If they're a small enough infant, you can put it around the edge of their foot. You might put it on their big toe, maybe on a thumb, wherever they'll leave it. Provide O2. You can initially start with a 100% non-rebreather, which is always the right answer in PALS. But any method of airway delivery that they're comfortable with might be appropriate. Just remember, if their nose is clogged with secretions, you wouldn't want to use nasal cannula. You would want to use something that covers their mouth also. Some kids aren't comfortable with the mask entirely covering their face, so they do prefer nasal cannula if their nasal passages are clear. Administer inhaled medications is needed, assist ventilation with a bag mask device or oxygen is needed, and be prepared to intubate if necessary. You also want to assess circulation. So you're going to monitor the heart rate, the heart rhythm, and a blood pressure, and then establish a vascular access as indicated. You want to identify what type of respiratory problem you're dealing with so that you can figure out your next interventions. There are 4 classes of respiratory problems: an upper airway obstruction, a lower airway obstruction, lung tissue disease, or disordered control of breathing. So obstructions of your upper airways would be those of the nose, pharynx, or larynx. So common causes are foreign body, whether it's an actual toy, it could be food, it could be something the child put in there, it could be swelling and mucus. Anaphylaxis, Tonsillar hypertrophy. Frequently children, they have large tonsils, and if they're infected, they'll be even larger. Croup, epiglottitis. Epiglottitis is common in children who aren't vaccinated, so have that in the back of your mind if you know you have a family who doesn't administer vaccines. A peritonsillar abscess, a pharyngeal abscess, thick secretions, or a congenital abnormality may make their airway partially obstructed. Signs and symptoms of upper airway obstruction. Usually you're hearing these sounds on inspiration. You're going to have tachypnea, they're breathing rapidly, increased inspiratory effort. So they usually will have their suprasternal retractions and nasal flaring. They may have some hoarseness. They're going to have the barky cough. They're going to have stridor, where you hear the sound on inspiration. Poor chest rise. There's going to be poor air entry. They can have cyanosis. Frequently, these kids are drooling because they can't swallow their secretions from all the swelling. They will have that cough that's usually barky. You'll see some seesaw breathing where the abdomen and the chest look like a seesaw from each other. And the respiratory rate is going to be mildly elevated. They're having to produce some work to get the air in. Management for upper airway obstruction. Again, let the child assume their position of comfort. This is a child you want to avoid causing them to cry. So generally on mom's lap, on dad's lap, however they want to sit. Remove the foreign body if possible. So if you can suck the bean out of their nose, if whatever's in their airway can be coughed up using Heimlich or whatever that might be. You want to suction the nose and or mouth, and again, consider their agitation level. If they are done having their nose sucked out and they're relatively stable, don't make them cry. Reduce the airway swelling with meds, so you'd want to consider steroids, Decadron, possibly a racemic epinephrine treatment. You want to minimize agitation. Again, get in, get out. They're probably going to be scared of people in scrubs, so be in the room as little as possible. Decide if an airway adjunct or advanced airway is needed. Maybe they're going to need intubated because you just can't maintain a safe airway. And decide early if a surgical airway is needed. So do you need someone on hand who's capable of performing a tracheotomy? Specifically, management of croup, something that you're going to see frequently. Consider dexamethasone. Humidified oxygen, the humidity in the oxygen is going to help the disease process. You do not want to feed them, so no more things to eat or drink, especially fatty milks, things that are going to make them cough, produce more secretions. You want to consider nebulized epinephrine. If respiratory failure is impending, high oxygen. So you want to try the non-rebreather, assist ventilations if necessary. Again, administer dexamethasone for sure, and you're going to intubate with an ET tube that's half size smaller than indicated for the child's age or weight. If your upper airway obstruction is caused by anaphylaxis, you administer IM epi every 10 to 15 minutes as needed, and know that multiple doses may be needed. You want to treat bronchospasms with albuterol. You can give a continuous albuterol treatment if indicated. For severe respiratory distress, anticipate that the airway is going to get more swollen and prepare for intubation. You can administer diphenhydramine and an H2 blocker IV, and you can administer methylprednisolone IV to help control the swelling and inflammation. Lower airway obstruction, this is what's occurring in the lower trachea, the bronchi or bronchioles, and the most common causes of lower airway obstruction in children is asthma and bronchiolitis. So those lower airway signs and symptoms are going to occur during expiration, where your body's trying to get the air out and is having some trapping. You're going to have tachypnea. There's going to be wheezing. It's usually on expiratory, but could be on both or just inspiration. Increased respiratory effort, retractions, nasal flaring, and the expiratory time is greater than the inspiratory time. And then an important thing to look at is the expiration is an active rather than a passive process. So they're really working to get that air out. And then also a cough. Management of bronchiolitis, and that's RSV, follows under that category. You want to perform oral and or nasal suctioning as needed, and kids with RSV generally have lots of nasal secretions. You want to consider labs, viral studies, and a chest x-ray. You can consider trialing epinephrine or albuterol, but studies show it's not always effective. And administer oxygen to keep your SATs greater than 94, and then of course, per PALS guidelines, if your SATs are greater than 99, you would wean. Lower airway management for asthma specifically is humidified oxygen via nasal cannula or mask to keep the SATs greater than 94. Administer albuterol, you could consider a continuous treatment. Administer corticosteroids. Administer Atrovent, a little longer acting. Consider establishing vascular access for administration of your fluids and meds. Perhaps they're breathing too hard to drink and they can get dehydrated from the tachypnea. And also you may need an ABG and chest x-ray. So if you have a child with asthma and you have impending respiratory failure, you want to make sure you're giving high concentration of oxygen. The continuous albuterol treatment, definitely IV corticosteroids. You can consider terbutaline. BiPAP will help if you have the masks that would fit. And then consider intubation if the oximetry is low and the conditioning is worsening. They're not able to stay awake and talk to you and answer your questions anymore. They have irregular breathing. Be prepared. So lung tissue disease. That is a group of clinical conditions that are going to affect the lung at the level where gas exchange occurs. So the alveolar and small airways collapse, or the alveoli become fluid filled. And examples of this are pneumonia, pulmonary edema, a pulmonary contusion, possibly following an accident or trauma, an allergic reaction, or toxins that may have been inhaled into the lung. You can see any of those with children in the pediatric population. Signs and symptoms, tachypnea. They are breathing fast. Increased respiratory effort, so using all their accessory muscles. Grunting, and then remember too, frequently if children are grunting, that respiratory rate's going to come down, but if they're done grunting, then they're tachypnic, so it may go back and forth between a fast rate and a normal rate. You're going to hear crackles when you listen to their breath sounds, which are probably going to be diminished. The heart rate's going to be increased, trying to compensate for all this, and you're going to have hypoxemia. So management of infectious pneumonia, of course, first are your ABCs. You want to consider CPAP, non-invasive ventilation, or mechanical ventilation. Diagnostic tests, your CBC, chest x-ray, anything, maybe swabs to rule out some things and decide your treatment from there. Antibiotic therapy, you want to start that early after cultures are drawn. You want to treat any wheezing with albuterol. If they don't have wheezing, that may not be necessary. And then reduce metabolic demands by normalizing temperature. That's important in children. They should be, the temperature should be normalized with Tylenol, but also if they are cold, you want to warm them up. The management of pneumonia, pneumonitis, I should say, inflammation of the lung tissue caused by inhalation or aspiration, and kids try to drink the craziest things. Infants, maybe someone's used baby powder and they've inhaled that. You never know what kids get into, but toxic liquids, gases, dust, or fumes into the lungs. Of course, first ABCs, you want to treat wheezing with a bronchodilator. Consider CPAP or non-invasive ventilation. And then if symptoms are progressing rapidly, you want to consult a specialist early to know how to treat those lungs specifically. Disorder control of breathing is a fancy way of saying that the respiratory center in the brain has been damaged for some reason, and that's why the breathing is not appropriate, not any kind of an infectious process happening in the lungs. So it's an abnormal breathing pattern that produces signs of inadequate rate, effort, both. So where you're going to see that is a kid that's having seizures, febrile seizures, epileptic type seizures, seizures following trauma, increased intracranial pressure, again, following a trauma. Perhaps it's a patient that has a shunt that's not functioning appropriately. Any central nervous system infections, they may have seizures or breathing issues. A head injury, tumors in the brain, hydrocephalus could be a cause for disordered control of breathing, neuromuscular disease, or metabolic disorders. So signs and symptoms, a variable or an irregular respiratory rate. For example, tachypnea alternating with bradypnea. A variable respiratory effort, maybe they're not having any retractions and then suddenly they are. You have shallow breathing, that it appears they're breathing, but it's not enough to really move oxygen in and out. Or central apnea, where the respiratory center of the brain just is not working and their brain's not telling their body to breathe. So specific management for increased intracranial pressure. You want to open the airway and maintain the airway while stabilizing the C-spine. So use the jaw thrust as necessary. Verify a patent airway, that they're getting enough oxygen and adequate ventilation. If there is poor perfusion, you definitely want to do a normal saline or LR bolus. Administer pharmacotherapy that specifically manages ICP, like a hypertonic saline. And then treat agitation and pain aggressively once their airway is established and ventilation is adequate. So once they're intubated, you really need to knock out their agitation and keep their pain under control, or that's just going to increase the ICP more. And avoid hyperthermia. Again, we want to normalize that temperature. Managing respiratory distress or failure due to poisoning. And again, kids get into things nonstop. You want to support the airway and ventilations. You want to call the Poison Control Center for directions. They are excellent at letting you know the antidotes and then calling at increments to check on the patient. Be prepared to suction the airway in case they're going to vomit. Administer an antidote if there is one, and then diagnostic tests. Perhaps there's certain electrolytes that you're going to need to follow. Children may have a neuromuscular disease, for example, cerebral palsy, and where they don't have an effective cough, or they have a difficulty managing their secretions. So you may need to be clearing their airway frequently, laying them in a position where the secretions are able to drain from their mouth instead of possibly occluding their airway. Obviously, we always cover ABCs first, and we could provide non-invasive ventilation through CPAP, BiPAP, high-flow cannula to help manage those. That's the end of our slideshow, and be thinking of any questions you may have during our Q&A section. Thank you.
So does anyone have any questions for Jen?
Hi, I'm Jennifer Jager.
Let me pull up the chat here and see if anyone has put anything in the chat. Jen, do you have any comments?
I don't think so. Pretty straightforward. You just need to identify which of the 4 emergencies, respiratory type of emergencies you'd be dealing with, and that dictates treatment. And again, that whole lecture is based on PALS.
So if no one has any questions, we will move forward and go to our next simulation.
Hi, my name's Jennifer. I'm going to be your nurse today. What's going on?
Well, she's just had a hard time breathing lately. She's not been eating a whole lot. She didn't wake up this morning for her feeding, and I can't get her to eat. So I'm just.
How much
just
does she
worried.
usually eat?
She usually eats about 4 ounces every 4 to 5 hours. And I just cannot keep her nose clean. She's just, she got this cold, and I cannot get control of this snot.
How many days has she had like the respiratory symptoms, the snotty nose and that?
It's been several days, probably 5 or 6 days.
Okay. Babies breathe out of their noses primarily, so we'll try to get that opened up so she can maybe breathe a little easier. Get a syringe. Has she had a fever?
No, not that I've noticed.
Okay. Any vomiting?
No, but she's barely had anything to eat.
Okay. Any wet diapers?
She had one wet diaper before she went to bed last night, but she hardly had anything yesterday at all.
Are her shots up to date?
Yes.
Oh, what's this? Yucky, yucky. What's her name?
Mallory.
Oh, I love it. Okay, we're gonna get her nose cleaned up a little bit, see if that helps. Just get an oximeter on her foot. This is just a light that shines through. It gives me an oxygen number of how well she's getting oxygen to all her cells. There's a lot of junk in there. Let's see. Dr. McCannon, could you come in?
Sure.
This is a 3-month-old baby Mallory. She's had nasal congestion for almost a week, not eating so well, not having very good wet diapers. I can hear a lot of upper airway sounds, congestion, and a little bit of wheezing. Cleaned out her nose pretty good, and our oximetry's like in the mid-80s.
Okay. Is she febrile?
No.
Febrile. Excellent. So we probably should start off by adding some supplemental oxygen.
Okay.
So whichever type that you can deliver.
I think with her nose so snotty, I'm just going to do this whole mask that whether she's breathing through her mouth or nose, she gets
Great
some.
idea.
Okay.
How long will she have to have that?
We'll just kind of see how her numbers do. I'll let Dr. McCanna do his assessment and kind of go from there. Fontanelle's a little sunken too.
Yeah. So we probably want to get an RSV swab also.
Ooh, okay.
And then did you hear some wheezing?
A little bit of wheezing now.
Okay.
It's hard to hear over there.
Maybe give a half dose albuterol, 1.25 milligram nebulizer treatment.
Okay.
See if you get any effects from that. Albuterol is a medication that's very similar to adrenaline, so it can have a side effect to make them a little bit shaky and stuff like that. So but it goes away. It's perfectly normal, but it helps to open the airways. So. Is anybody else in the household sick?
Her big brother had a cold a couple weeks ago. He still has a little bit of a cough, but
Okay. Has she had medical problems in the past?
no,
Okay.
she's been healthy.
She turned baby.
Yeah.
Mom, I'll have you hold this if you don't mind. You just hold it up close to her face. I'll get this stuff for an RSV swab. She's probably not going to like this. I'm just going to go back down her nose to the back of her throat. She might gag and sneeze. It'll be real quick, and that's all I have to do. So I'm just going to have you move the mask for a second. Okay, thank you. Oh, good girl. We'll send that down for lab.
Yes.
What do you think about starting an IV?
I think she probably does. I think she's just a little bit. Has she been eating well?
No.
Not well. Yeah, we probably should start an IV. Give her a
She
little
only
bit of
took
fluids.
like 2 bottles yesterday. Only about a half a bottle each time.
Okay. We draw some blood off. We do it.
Yeah.
CBC, BMP.
Okay.
I'll call radiology. We'll get a chest X-ray also.
Okay.
Because you did hear some wheezing.
There we go. I'm just gonna put this rubber band on first. And look for a second. Okay, little firm, baby. Treatment's about done. Just want to see what her sats are in room air. She has pretty good intercostal, subcostal retractions.
Yeah.
Okay, Mom, we're going to switch back to the other. Take this off her face.
Take a quick listen to her lungs too. We change that oxygen mask out. Let's see. The lungs sound more clear now after the treatment, but it does sound like there is a little bit of upper airway disturbance going on. Mucus.
Yeah, you can go ahead and hold that. Quickly drop down to the low 80s with me, just switching from that treatment to the back to the rebreather.
I think that she's going to require some higher flow oxygen needs. Do you guys at this hospital have any high flow oxygen as a vapotherm, max flow junior, anything to run high flow oxygen greater than, let's say, 40 liters?
I don't even know what that is. I can call the respiratory therapist because they've gone home for the day. Nobody comes until 8 tomorrow, but
I think,
don't think.
I'm pretty sure in this case it'd be better if we transfer.
Okay.
So would you like me to give a call to our local facility we can transfer to?
I think so.
Okay, so in your facilities, how would you handle this situation? Anybody? So Sarah is saying that they have a vapotherm, but would probably transfer this child out. And Brad is also saying pretty similar, but with the exception of they do have RT 24/7, and they do have both high flow and vapotherm. Brad, where are you from?
Woodlawn Hospital in Rochester, Indiana.
Woodlawn. Okay. So you would get everything set up and then you'd go ahead and transfer this baby out.
Yeah.
Yeah. Okay. Would anybody keep this baby? All right. It sounded like no. So that's good. That was kind of the point was encouraging transfer. Especially if you didn't have that higher flow oxygen or respiratory coverage 24/7. Does anybody not have respiratory coverage 24/7? Looks like Kim isn't on here anymore. I know that some of our hospitals in our cohort do not have respiratory coverage 24/7. That we wanted to stress. Having a respiratory therapist available for these kids and getting them transferred to a higher level of care. Do our subject matter experts have anything to suggest after watching the video? Is there anything you would have done better?
I just want to, I talked about it in the lecture, and then again, it was done in the video, but something that we see on the pediatrics unit and it needs done repeatedly is remembering that a lot of the younger the infant is, the more they rely on their nasal passages to breathe. So you may have cleaned their nose out when they first got here, but it may need cleaned out again in 15 minutes. So just staying on top of keeping their airway passages as open as possible from those secretions. They produce a lot and they need sucked out, cleaned out. They're going to hate it, but trying to have mom on board with helping you watch that to keep those nasal passages open so that they can get as much air in as possible.
Okay. Sarah is asking when and if you would do blood gases on these respiratory infant and children cases. Is there a criteria to do these?
That's a great question. So there's no black and white guide when to draw blood gas on these patients. It's really got to be a clinical bedside decision based on the given patient scenario that you have at that moment in time. That's not going to hurt anything. I mean, anytime you do an arterial stick, you have a certain level of complications that can take place, but a blood gas gives you a lot of information. So when I think about a blood gas in these situations, what I think specifically about is I want to look, obviously, pH is always a concern, but I'm most interested in their PO2 and their PCO2. So are they oxygenating and are they ventilating? And these RSV kids, we need to make sure that they're oxygenating. So a pulse oximetry most of the time will give you that information, which of course is non-invasive. But I would say if you have any questions whatsoever, don't hesitate to draw a blood gas and get those numbers, and you can see the whole picture very clearly then. That's a good question.
Any other questions? Okay. So I want to take a moment to thank everyone for participating with us. I know we're all getting used to this environment now. And we know that the ideal situation is that we would be in your facilities and we would be doing this in person with you, and you'd be getting your hands on everything and practicing. But we hope that this was able to make up for it a little bit. And hopefully we can see you again in the future. If you have any questions, we encourage you to contact us, and we will be getting these recordings out to you once everything is complete, so you can share them with your facility. This is not the ending. I'm going to ask you to take a post test, and I'll pull that up here. And I will leave this up for about 10 minutes or until everybody's finished and logged off. I'll leave this up. The post test is the one on the right-hand side here. Same questions as before. Hopefully we've answered all the questions for you. And then we also want you to do the event evaluation. And as I said before, this really helps us determine whether what we're doing to make up for not meeting in person is working. So if you could please take both of these. Once again, just scan the QR code. If you have a QR reader, you can use that on an Android phone, or if you have an iPhone, you can just use your camera and scan over the QR code. There's also a link you can type in, or I will put these links in the chat. Once again, thank you for participating. It really helps if we actually have some participation. So thank you so much for participating. And just let us know if you need anything.